Amazing. All right. Hello, everyone. We're really excited that you're able to join us for our third and final admin burden report share out. My name is Abigail Fisher and I use she, her pronouns. And today I will be presenting the results of the admin burden CCAR DACODS Modernization research. I'm an experienced designer on the BHA Technologies team. There are lots of members of the BHA technology team, and you can see some of those roles represented on this slide. I want to thank everybody on our tech team because all of the folks on our tech team contributed to this body of work, but I want to especially shout out co-authors of this research, Chris Pimlott and Mark Gammon. We'd like to begin with a land acknowledgement drafted by the Denver City Council. We honor and acknowledge that the land on which we reside is the traditional territory of the Ute, Cheyenne, and Arapaho peoples. We also recognize the 48 contemporary tribal nations that are historically tied to the lands that make up the state of Colorado. We honor elders past, present, and future, and those who have stewarded this land throughout generations. We also recognize that government, academic, and cultural institutions were founded upon and continue to enact exclusions and erasures of Indigenous peoples. May this acknowledgement demonstrate a commitment to working to dismantle ongoing legacies of oppression and inequities and recognize the current and future contributions of Indigenous communities in Denver and across the state of Colorado. We thank the Denver City Council for those words. So today we'll be going over our research findings and our recommendations for a roadmap forward to modernize CCAR and DACODS. This session only marks the beginning of a more comprehensive engagement period for these recommendations to ensure we are truly holding space for co-creation with providers and people seeking care in Colorado. In terms of the structure for today, I'll be presenting out for around 30 minutes to 45 minutes, and then we'll hold about 45 minutes for discussion. Although we might not have all the necessary people or information to answer all of your questions, we will follow up with answers as we need to, answering live as much as we can. We know that many providers are eager to give feedback on this work, and we have many ways for you to engage and share your thoughts, including in attending live sessions like this and engaging in live discussions. During this session, we do want it to feel as much of a conversation or discussion as possible. So feel free to share your thoughts in the chat while I present. I won't be answering the questions as I go, but I will begin our discussion session by answering all of the questions in the chat. Finally, for those who prefer to give their feedback anonymously, we have a feedback form, which Megan, my colleague, will put in the chat that anybody can fill out anytime before October 27th. This form is also posted on the project's website, which Megan will also share. Every piece of feedback that we get will be posted and responded to publicly by the BHA. And we'll talk more about this feedback and stakeholdering process at the end of the presentation. And finally, before I jump in to the meat of our content today, we want to deeply thank everyone, especially providers who participated in this research. We know that every hour spent with us is an hour away from supporting clients. We take this responsibility very seriously, and we credit the recommendations in this report as solutions created by those closest to the problem. As I go through the rest of the presentation today, one of the questions I would like you to consider is, would the recommendations presented in this report better balance administrative burden, federal requirements, and the need for measures of quality and access? To add some more detail here, we know that as the BHA, it is our job to balance how federal requirements place administrative burden on providers. These federal requirements seek to establish measures of quality and access for the state's behavioral health system. Today, however, we know that these factors are not in balance from the experience of providers, and this report specifically seeks to address that imbalance of administrative burden. Addressing administrative burden and balancing that against measures of access and quality are even baked into the BHA's founding legislation. It's something we're taking very seriously and are acting on with urgency. And this slide is an extract of House Bill 22-1278, which created the BHA. and in which you can see in this portion of the bill highlights the importance for access of care measures, quality of care measures, but in point F also acknowledges the importance of reducing administrative burden for that data collection. We know that this current iteration of the BHA stemming from OBH is a little over a year old, and we're still very much digging our way out of technology debt accrued by our predecessor over the years that it was, live in the state of Colorado. We know that this technology debt pays a large part in the high levels of administrative burden currently experienced by providers engaged with the BHA. And we know that it is our job as the BHA to address this. This report provides recommendations to put in better balance the administrative burden caused specifically by CCAR DACODS reports. This will be one of many projects at the BHA to address many different causes of administrative burden, as we know that CCAR and DACODS are not the only causes. To begin, I want to start by sharing what our key recommendations are, and then I'll take you through the process of how we arrived at these recommendations. Our first recommendation is that it's necessary for us to update the data model for CCAR DACODS, and we must do this through relevant community stakeholdering with providers, with people seeking care, and the federal compliance review process. Part of this update to the data model will involve using more culturally competent language for data elements like gender, race, and ethnicity. And we'll talk more about this in detail throughout the rest of the presentation. Next, we know we must select a new data entry technology system. We need to perform an analysis of existing and potential new technology systems based on the recommended design parameters coming out of this research in order to select a new front-facing data entry system to replace the current CCAR and TMS systems. We must build both the technology system and our data model for episodic reporting. And by that, I mean, we're building an environment where we can collect longitudinal data and aggregate encounters into episodes of care so that providers can get more holistic, whole person information on the client that they're seeking to care for. Next, we need to share this data. So to do that, we need to create data analysis dashboards. To begin, we'll have some standard and potentially customizable data analysis dashboards so providers can do things like track progress towards contractual requirements, as well as other important measures of equity. And finally, underpinning all of these recommendations and what ultimately hinges on the success of this project is creating a robust external communication and engagement plan for providers and other stakeholders, including people seeking care, to foster trust and transparency in this process. So, if those are our recommendations, let's begin to unpack how we started. Why was this research conducted in the first place? Those on this call can speak to this far better than I ever could, but we know that behavioral health care providers that care for uninsured, underinsured, and undocumented people have to hurdle extreme bureaucratic barriers. We know that even accepting insurance is a hurdle for behavioral health providers, much less Medicaid. We know that Medicaid is more complicated. And then if you add any other state agency funding stream or program, the administrative requirements can quickly double or triple. This visual demonstrates that the more requirements you have, the more technology systems you must engage with as a provider. These factors create really complex tech ecosystems that far outweighs what providers that only accept private insurance face. And here's an example in this visual of what a provider might experience if they take Medicaid and also happen to access a BHA program. And we'll acknowledge this isn't even a full list of all the things that provider would have to do in order to remain in compliance with the state. Understanding the facts that we just covered, it's easy to see the connection between the behavioral health workforce shortage and the high levels of administrative burden experienced by providers who access public funding in Colorado. I think we've all seen and experienced these news stories and what it feels like at an organization to be short-staffed. This report is one piece of a broader state effort to address this problem. There are many efforts at the BHA and across other state agencies to address administrative burden. And we know that part of that cross-agency functionality and that cross-agency collaboration is especially critical here. This report is the BHA Technologies team contribution to that wider body of work. We have and will continue to share these findings and collaborate with other efforts and other agencies in order to maximize our impact. We know that one of the major causes of administrative burden at the BHA are CCAR and DACODS reports. Providers that engage with the BHA through contracts to either access additional funding and or provide opioid treatment programs must fill out CCAR DACODS. CCARs at a high level are for mental health services, and DACODS at a high level are for substance use services. We have more detail within our full report found on the project website on which providers must submit CCAR and DACODS. And Megan will share that link to the website again, where you can find that full report and that deeper level of detail. As we stated at the beginning of this presentation, we understand that there are many sources of administrative burden caused by the BHA, but we very intentionally began with CCAR DACODS because those reports today are the most prevalent and the most harmful to providers. As we begin to tackle the administrative burden related to CCAR DACODS, we will also in parallel begin to tackle other sources of administrative burden. You might ask, why can't we simply not have CCAR and DACODS? And that is a very valid question. Unfortunately, we cannot simply do away with CCAR DACODS. And this diagram seeks to explain the flows between money and reporting in our federal partners. CCAR DACODS stem from reporting requirements from SAMHSA that allow the BHA to receive block grants, which are then passed on to providers as funding through BHA programs. This is similar to how CMS requires reporting from HCPF on Medicaid enrolled providers. Many people have rightfully asked, why can't the BHA simply pull the necessary data from other sources, like from HCPF? Unfortunately, we found that there is enough difference in the type of data required by SAMHSA that there will likely, at least for the near future, always need to be some data collected from providers by the BHA. So if that's the bad news, we do have lots of good news. There's much we can do to improve data quality, tech usability, and to reduce administrative burden while collectively still remaining in compliance with federal requirements. For instance, we know that one of the major pain points for CCAR DACODS is the aging technology. We want to shout out our system specialists who have helped to keep these systems going in the face of limited resources for nearly 20 years, but acknowledge that anything after 20 years is likely in need of a lot of updates, especially pieces of technology like this. Next, we also know that the data model, like we've talked about previously, is outdated and harmful. For instance, today, CCAR and DACODS requires providers to ask clients their sexual orientation, something providers typically would not ask in their intake processes. There are certain questions that the CCAR and DACODS reports must ask because they are dictated by the federal government. Other questions, however, were added by OBH because they wanted to collect additional demographic information for state data analysis. Our recommendations include minimizing data elements to only those that the BHA can solidly defend, either due to federal requirements or a strong use case for quality and access measures that would be shared back to providers and the general public. I want to make clear that what this slide says is not recommending that we remove the sexuality requirement from CCAR and DACODS. But what rather it is saying is that we need to do work with providers and with people seeking care about whether this is important information for this specific report at the BHA to collect, if this information is being collected elsewhere, and what we feel comfortable with moving forward with this updated data model. And we'll talk more about that collaboration process later in the presentation. In summary, it's imperative that the BHA address the administrative burden and negative impact on provider-client relationships caused by CCAR DACODS, while also remaining in compliance with federal requirements. The recommendations that follow in this presentation will address those concerns. The proposed roadmap will also consider how this work will integrate and support other administrative burden efforts across the state. We want to spend just a couple of minutes giving you some information on our research methodology. So, like we've talked about already, we focused our research on CCAR and DACODS, but I want to pull up an original language from our research focus because it's especially important to see how we called out the emphasis on how administrative burden impacts clients and people seeking care. Ultimately, the BHA mission is to improve behavioral health care for people in Colorado. So we find that it's important that all of our work has this ultimate lens of how does this impact people seeking behavioral health care. We executed both primary and secondary research during this project. From March through July of 2023, we talked with 16 provider organizations across Colorado. Those organizations included representation of a variety of tech setups, geographies, EHRs, mental health settings, service offerings, and population expertise. We conducted hour-long interviews and virtual site visits with each of those 16 organizations, and over 60 individuals from those organizations participated, including roles stemming all the way from clinician to front desk staff, to data and tech teams, to clinical managers, to executive leadership. So a really good representational sample. We also did extensive secondary research on federal and state policy, legislation, and past modernization efforts like Compass. Our methodologies at the end of the day are informed by the practice of co-design and the importance of designing with and not for, building towards an ultimate vision of communities closest to the issue at hand, designing solutions for and by themselves. If you want to read more about co-design, our team highly recommends the book Beyond Sticky Notes. All right, so what did we hear from all of that research and what underpins all of our recommendations? We have a couple of top findings to share with you, and hopefully it becomes clear how these findings directly relate to our recommendations. So one of the things that we found that will not be a surprise to anyone is that the data model underpinning CCAR DACODS is clinically and culturally out of date, especially for data elements like gender, race, and ethnicity. We heard that providers are losing out on payment and accurate counts towards contractual requirements because of how inflexible BHA tech systems are in terms of how they intake data and an inefficient error resolution process. We heard that the distinction between CCAR for mental health and DACODS for substance use perpetuates the siloing of behavioral health care and creates high levels of data duplication for the rising population of dual diagnosis clients and providers. Like we talked about, we know that our tech is aging, and that leads to basic usability issues around account management, logging in, system timeouts, copy and paste, which in turn increases the time, effort, and cost required to submit compliant data by providers. Today, we know that the data generated by CCAR DACODS provides limited benefit to the state's ecosystem at large. The data is only currently in active use primarily for contract and funding requirements, not any larger data analysis that is publicly shared. And finally, and we talked about this in our research focus, and some might say most importantly, these reports are directly and negatively impacting how people experience behavioral health care in Colorado, especially for those intake appointments that we discussed. For those of you that are more visual learners, we've also created a clinician user story, which summarizes what we heard from providers about the experience of collecting and submitting reporting. The major takeaway here being that it can, for one single client intake appointment, it can take anywhere from 30 minutes to 1 hour to collect and submit BHA reporting. Multiply that by a full caseload and multiply that caseload by an organization, and you begin to see the magnitude of this admin burden. I'll pause just for a minute in case folks want to read this, but also know that these slides are on the project microsite that Megan has been sharing in the chat, so you can read them at any time. All right. So I mentioned data strictness. One of the major factors causing admin burden for CCAR DACODS reports is the data strictness required by BHA tech systems. The BHA today requires a customized file format that is not supported by most EHRs without customization. That means it's up to each provider to create unique processes and systems in order to successfully create and submit this file type. Our recommendations highlight the need for more data flexibility for this reason. And finally, in terms of our findings, we want to specifically highlight what we heard about why CCAR DACODS are inappropriate for many of our priority populations today, leading to data inaccuracy. So to begin, children, youth, and families. We know that the CCAR today is not tailored to infants and children, so we must explore other reporting mechanisms and/or ensure that training materials provide specific clinical guidance for this population. One of the things that we heard is that it's not appropriate for behavioral health providers that cater to infants to provide a diagnosis upon admission, which the CCAR requires. So there are things like that that are causing this to be inaccurate in terms of data for children and infants. For undocumented people who can be rightfully reluctant to provide information about themselves or their family, we heard several times from providers that they wanted guidance from the state about how to approach reporting requirements for this community. For LGBTQIA plus folks, we heard again that the only reason that providers are asking about sexuality in intake appointments comes from CCAR DACODS reporting requirements. And then we need to talk to providers and people seeking care with this identity to understand the benefits or the negatives from collecting this type of information continuing in the future with CCAR and DACODS. People who speak Spanish, we heard that the race and ethnicity options are very confusing, particularly for folks in Latin people. For unhoused people, we heard from providers that the drop-down options for housing status are completely inappropriate and lead to data inaccuracy. And finally, for opioid treatment program participants, the language for drug types and administration methods are not accurate or up to date. For example, there is no option for fentanyl or vapes. This means that our recommendations really need to anchor on how changes to the data model and training processes and materials will address these concerns. And it's also particularly important to take into account how we will continue to engage these priority populations and providers that care for these priority populations in changes and updates to the data model. So I hope at this point it's clear how our findings have built to our recommendations we reviewed at the beginning of this presentation. I'm going to put them up on the screen again, just in case you want to have a bit of a reminder. Again, our 5 key recommendations at a high level are update the data model, select a new tech system, build both the data model and the tech system for episodic reporting, create data analysis dashboards so we can better share data back to providers, and finally, prioritize engagement with providers and those with lived experience on all of these updates to this report type. Today, we want to talk briefly about the 3rd recommendation, moving from encounters to episodes of care. The rest of the detail on the recommendations can be found in the full report that is linked to on the microsite that Megan has been sharing. And again, that microsite will be the place to go for anything that you might ever need on this project. But today we want to dig in briefly to the 3rd recommendation. So to define, something we've heard from providers across a variety of research efforts is that having a more comprehensive understanding of a client's history with state services would help those providers to better make care decisions. We believe that we can begin to pilot providing that more longitudinal understanding of clients' care history by linking together different service level reports, including CCAR, DACODS, and 837 encounters. And that's to provide a more holistic data story of past treatments so providers can get that more whole person picture. Visualized here, we believe that by moving from encounters or CCAR admissions and discharges, instead we could provide real benefit back to both providers and clients by tying those together into episodes of care, which you can see in those yellow blocks. Ultimately building to a better picture of the lifetime care journey of that client pictured in the last bar. This effort will, of course, require heavy work with people with lived experience in order to understand appropriate levels and methods for gathering consent. For the sake of time, again, we've left the rest of the detail on these recommendations for folks to read on their own time in the report, but we do want to talk about when these changes might occur and what our roadmap looks like. This tentative timeline represents what we as the BHA can commit to in terms of moving these recommendations forward. We put the updates to the data model and the updates to the tech system on different tracks, each with different engagement plans and methods. But the way that we've set up this timeline at the high level will ensure that we can engage community in co-design at every step of the way, that we can engage in pilot projects and iterative testing across the entire timeline. And likely what will be good for you all to hear on this call is that we'll be releasing a more detailed timeline within the next few months. But at a high level, we want you to understand that we will not be requiring any changes to CCAR DACODS for at least 1 year after our new specifications are released, in order to be respectful of providers' timelines as they update their systems. So if we go back to this timeline, what that might look like is that tentatively, we might have those specifications done by July. So that is when that 1 year clock would start. I want to talk a little bit about iterative product design and management and how we avoid getting into the same situation that we are in today with the CCAR and TMS technology systems. And that really anchors on the principles, again, of iterative product design and management, which in short, favors small bets, iterative pilots, and testing rather than a singular magic bullet vendor partnership. So traditionally, government technology is built with a build it once for forever mindset. This method means that user feedback is typically not collected until it's too late, and that constituents are forced to use bad and antiquated technology until it literally dies years later due to filtering systems and software so old that it legally cannot meet today's security requirements. So in that product decay, that is where we are with CCAR and TMS systems today. But we've learned a lot as a government and a civic technology community since those platforms were built. And we have an understanding today that iterative product design and management is a far more effective way to build this type of technology. The roadmap outlined in this presentation is anchored in iterative product design and management, ensuring that the tech systems are built for change from the very start and that feedback can be implemented throughout the entire life cycle of a technology. This ultimately saves the state money and drastically improves user experience. And finally, we understand that the success of this modernization project hinges on accurate, transparent communication and engagement opportunities. We know we must look beyond a technical solution and into the principles of co-design and co-creation to move this body of work forward. A robust engagement plan will be formulated, including the following considerations on the slide, which in essence just encapsulate our commitment to engaging and providing agency for both providers and people with lived experience around this initiative. Thank you so much for hanging in there and listening to me as I go through this full presentation. A couple thoughts on next steps, and then we'll hand it over to you all for discussion. So first of all, we have a couple of calls to action for you. One, we'd love you to read the full report. There's much more detail there than we can pack into a presentation. And there also are video recordings of this presentation and the other sessions that we held this week in case you're curious about what questions other providers had. These artifacts will all be on the project website, and they all are there today. Next, we would ask you to submit feedback via our feedback form in case you want to submit written or anonymous feedback, and that will be open until October 27th. All feedback submitted will get a response from the BHA and will be published. So that's important to consider if you want to make your feedback anonymous or not. And then finally, we'd love you to sign up to get email updates on progress for this project and for other projects that the BHA HIT team has going on via a sign up form that Megan will put in the chat. In terms of next steps, like I mentioned, we'll be collecting that feedback until the October 27th. We're hoping that we can publish responses to that feedback on the BHA project site by mid-November. And then the week following the publishing of those responses, we'll hold 3 more share out and discussion sessions that will be scheduled, and will follow a very similar format to this meeting here today. At that time, we will also be promoting additional ways to engage with this effort. And we don't know exactly what that will look like yet, but it could be something like a working group for data model updates, as well as for tech selection. And with that, I would like to open it up for discussion. As a reminder, this is the question we wanted you to think about and mull over as I presented. I'm also going to launch a poll that asks the same question in case you want to participate in that way. And then I'm going to stop sharing my screen, though I can go back to any slide at any time, and would love to just hear what questions you have for me that we might be able to answer for you today. And you can add questions in chat, or you can come off mute. You can also use the feedback form, whatever you're comfortable with.
Hi, Sarah Reed from Mental Health Partners. If I could jump in with a question.
Yeah, of course. Go for it, Sarah.
I'm wondering to what extent that you all will look to existing tools that are out there as a replacement as opposed to modifying the CCAR DACODS as they are now.
Yeah, so Sarah, we will not be modifying the CCAR TMS systems. There will be a wholesale replacement.
And would that look, and similarly, you mentioned the Compass DII kind of effort, would that look similar to that? And the thing behind my question really is seeing the tie to the why. Why can we not just do away with CCAR DACODS, and knowing that there's a federal regulatory requirement behind that that's largely driven by SAMHSA? are you all looking at the NOMS, the National Outcome Measure Set, as a replacement for that, given that it's already a SAMHSA required tool?
So yeah, I want to break that down into a couple
Yeah,
of different
there's a
parts.
lot.
Yeah, no, but great.
Appreciate it. Thank you.
So I think I don't know today about the technology system. And if we go back to that timeline, which I will share up, that's kind of the next couple of months. Like that is our task to really dive in and to provide more information to providers and to give providers a chance to react to a selection of a tech system. So that's kind of that piece. And then the second piece of your question around NOMS, we are doing an analysis to really understand, like, based on new licensing structure, who specifically has to submit CCAR DACODS for which specific clients. And then I think we can also add in, maybe a specific addendum on NOMS, because we've been asked that question a couple of times. So I can promise a response to that. I think, and Ria is on here. I don't know if anybody else has the answer. I think we have looked into NOMS, and I still think that the data needed is different enough to still require, an additional effort by the BHA outside of the NOMS. But we're also looking into how do we standardize how we collect demographic information, and if we can match those standards at a federal level, and also things that are happening on an international level that impact how EHRs structure their data. So I hope that answers some of your question, and Ria and Justin, let me know if I got any of that wrong.
That was right. We are currently looking into that overlap in federal reporting requirements.
Excellent. Thank you. That really helped a lot. Thanks.
I just wanted to pull this timeline slide back on and add one more thing. So Sarah, again, based on this tentative timeline, we have that share tech proposal around like November or more likely December, and with a period for gathering public feedback. So that's when we can promise to have like more detail around the tech system. I hope that's helpful. Cool, getting a thumbs up. All right, Brian, I think you're next.
Yes, hi. Thanks, Abigail. I apologize. I'm late to the party on this. I've been interested in this for a long time. I went down and talked to OBH in 2014 about, about some of the things you guys have identified, and you've really done a great job of nailing down some serious issues. We are an SUD outpatient treatment facility and have been through a lot of this and would reflect basically everything you found. And again, I apologize for being late. I just have a couple of questions, and if they've already been answered and they're in the documentation, if you would just kind of push me off to that. I've got the links that Megan put in here. First one would be, how are you engaging, or do you plan to engage with the EHR vendors to work on this?
Yeah, great question, Brian. So we at the BHA technology team are in the next couple of months are going to be embarking on a comprehensive EHR strategy in which we understand from all of our platforms at the BHA, how could we engage EHRs and EHR APIs and automation. So this particular project will, pull in whatever findings come from that effort. And we're doing that to do that more comprehensively. So we're not kind of doing whack-a-mole with EHRs, and instead kind of have more of like a broader piece of guidance for them. So hopefully in the coming months, I can provide some more detail on it.
Good. Okay. Second one was one of the problems that starts the issue is the amount of documentation that must be generated. In our case, we do, again, SUD. We're involved normally with criminal justice referrals, and we have to document, clinical notes for every encounter with every client. That in itself is a huge amount of typing, independent of the system that we type it into, whether it's into the EHR or into DACODS or something else. Has there been any talk at all about decreasing the amount of notes that actually have to be entered into a system? in behavioral health care, a day or a week is not necessarily a big change in anything. It can go months. Has that ever been approached at all? Just the clinical aspect of how much documentation is effective, is optimal?
Yeah, so I'll break that into pieces. So right now, like in this new version of the CCAR DACODS, I think we're going to validate a fact that providers have known for a long time, which is that this is not a clinical or a diagnostic tool. This is a reporting tool.
Yep.
So, we have federal requirements that they use to make inferences about behavioral healthcare across the nation, right? And that's the type of information that they need. There shouldn't be, to my understanding of the CCAR, like clinical notes, especially not in the new version that we will be putting forward. So hopefully that will help. I can't speak to like what requirements your organization requires of clinical notes. Like the state really has nothing to do with that. That's more about how clinicians build their care journeys or their care plans. So that would be my answer to your question, Liz. I think we will certainly address that in the updates to the data model.
Got you. And then third, finally, you mentioned earlier, how do we know what works? And of course, I think I think outcomes measures are a giant gaping hole in all of this. We hardly know what works or who works or when it works or anything in many cases. And I would love to really get involved in that. Where does the work on how that analysis of treatment effectiveness, where does that fit into this?
Yeah, so I'd love to direct you to our data team at the BHA, the Bay team. And Brian, if you put your email, or you can, Megan, if you put my email in chat, and Brian, if you send me an email, I can help to make those connections. But I'd say for this particular effort, we will be considering like what data can we provide back to providers, right? That will be helpful, not in like care necessarily. I'm sorry, Joseph, that is like the cutest thing I've ever seen. That is the best part of my day. Joseph has a dog on camera, so that's making me very happy. What probably I would love to talk with you about on this effort is like how you would want to use CCAR DACODS for your particular organization, and then Colorado CCAR DACODS in aggregate, like how would help that make your organization more impactful. And if you go into the report under the data analysis section, you can see a little bit about what providers have already said would be helpful. So if you want to anchor like your feedback in the feedback form on what you think would be helpful, I would really love to hear that feedback from you.
Okay, thank you. That concludes my litany.
Great question. Thank you so much, Brian. Those were excellent. Awesome. What else from folks? And if we're starting to wind down a little bit, what we've done in other groups, just to be conscious of folks' time, is that the BHA technology team will stay on here until the end of our meeting. But if the questions are slowing down, folks can feel free to log off. We'll keep the recording going. But we also had kind of like not a ton of questions on the other meeting. So up to you all. We'll be on here until the end, but if you want to log off and engage in other ways, we appreciate your time.
I do have some data related questions if that's appropriate at this time.
We can really, the team that we have on here is really best situated to answer questions about CCAR and DACODS in this report. But Brian, if you want to email me any questions that you might have, I can help to get you to the right folks.
Well, this is kind of DACODS data
Okay.
related. So, our EHR, which is ReliaTrax, is my understanding there are 300 OBH, BHA licensed agencies in the state who use that system. So clearly, it's from a numbers perspective, it's huge. We have 1,000 active clients running on ours now. We don't capture everything in our EHR that the current DACODS, and I assume that the newer one will require. So there needs to be some place where we can take everything that we do have, name, address, city, state, zip, et cetera, et cetera, et cetera, demographics, and a lot of the current things, and transform that into into something that goes into whatever the replacements will be. But then there are pieces that are not left, that are left that we do not have anywhere in our EHR. The EHRs are, of course, reluctant to make a lot of changes to the system without, kind of on a, maybe they'll need this and maybe they want that. They don't want that. So to me, there needs to be sort of a third system in here somewhere, perish the thought. That is, if your EHR doesn't have this information, here's how you can supply it. So I just wondered if that's part of any of the DACOD's design criteria.
Yeah, that's a great question. Oh, and we got another baby on here. This is the best. This is a great meeting, you all. So Brian, yeah, let me break that down into a couple of different answers for you. One, we as the BHA have to be a little careful around how we work with EHRs to avoid giving any one EHR a competitive advantage. So that kind of goes back to why we're doing an EHR strategy holistically across all of our technology platforms. So we can kind of be fair around that. So that's one answer. Another thing I want to provide to you is that how we build our tech systems has to work for our smallest and most rural provider, as well as our largest, most advanced with the fanciest EHRs. So we will have to create a web app system, however you want to call it, because there are certain providers that don't have access to Wi-Fi all the time or broadband, and also themselves potentially don't use EHRs, or certainly not EHRs like that are that advanced. So that's a little context there around like how we will translate data from an EHR like into the tech system. We are likely going to be providing different ways for different types of providers to submit data. So we know that for a larger provider, you guys aren't going to want to do manual inputs, right? Because you have more advanced systems. So we will be working in tandem with that comprehensive EHR strategy to provide more detailed guidance for EHRs. And at that time is probably when it would be appropriate for us to sit down with different EHRs, like maybe in some kind of working group, to go through that guidance together. That's a little bit forward thinking. Like, I don't know exactly, we don't have enough information today to put that on a timeline, but that's in general sort of the process that we're building around that. And I want to pause and see if Justin or if Ria want to, add anything, or if Brian, that, answered your questions. It looks like Justin and Ria don't want to add. So Brian, oh, nope, Justin, do you?
I was waiting for Brian to see if he had gotten the answers he needs. I think, Abigail, you hit the nail on the head. We know EHRs are going to be important. We know that not everyone has an EHR. We need to address both ends of that spectrum.
And that's really a nasty problem because some of the smaller agencies don't even use spreadsheets. It's on paper, and that's just not going to work. So some level of training, I think, might help kind of raise all the boats a bit. I don't know how much, but clearly automation is a big help to this documentation problem, and the more the better. One thing that we've wrestled with this, and of course. I was on several task forces for data exchange and over the years, and one of the issues always is there's so many different systems of so many different protocols and standards and blah blah blah. And a couple of companies have sort of popped up in my field of view in the last few years that are working with HEIs, health information exchanges, And I'm just wondering if there might be some method that some kind of universal exchange mechanism like an HEI where they take the responsibility for getting the data from all these systems, and you guys only have to worry about taking the output from that, rather than trying to be the ombudsman with an octopus trying to please everybody. If we can find some kind of consolidated system that we could contribute to and pull out of that aren't extraordinarily expensive, because like a lot of the smaller agencies that don't have technology, $5,000 a month to contribute to an HEI is unaffordable. Might there be a middle system here somehow we could take advantage of to help with the transfer problems?
Yes, and so I want to rewind 30 seconds to automation is helpful. I do, for anyone else who's watching who doesn't have an EHR, please rest assured that we are not going to force you onto EHRs, nor are we going to. Our goal is to meet the providers of Colorado where they are, and make sure that we are building tools for everyone, and make, if people want to shift more towards some of these EHRs and automations, that we make that easy. But we also want to make sure that we're not forcing it. To the question of HIEs, yes, HIEs are a big part of the ecosystem. In the same way that we will be putting together a comprehensive EHR strategy, we'll be putting together a comprehensive HIE strategy, including the new social health information exchange that has recently been procured by the Office of eHealth Innovation. And we are working closely with that team to make sure that as we move forward, we're not just dealing with mental health and substance use disorder, we're also dealing with physical health on the HIE side and the social determinants of health on the SHE side. And we are working on in various ways with our own technology, with the HIEs, with the HIE-like entities that exist in Colorado already for behavioral health, and with the social health information exchanges, to make sure that we are tapping into data where it is available. We are making it easy to share data where those pathways already exist, and that we are creating new pathways where they don't exist, so that we make this as easy as possible for those who do have automations, and we enable those who are not currently tech leveraged to participate in the ecosystem that we are creating and not leaving them behind.
Good. And does Snowflake fit into one of those scenarios?
Yes.
Okay. Good.
Yeah, the
I'll be
only
joining more frequently now, by the way. I'm sorry I was so late to the party, as I mentioned earlier. I've been had a lot of conflicts with this time slot and technology.
No worries. We really love your feedback, Brian. Thank you so much. The one thing I would add is that once we get a little farther along in what our tech selection process will be, one of the activities we will do is a cost analysis about how that proposal will impact different, levels of providers, different sizes of providers, and to investigate whether there's like funding available to support in these updates. So that will also be forthcoming. Any other questions? Okay.
I will say, Brian, seeing as you do seem to be quite interested. One of the things on the timeline slide that you may have noticed is that we will be running pilot projects and proofs of concepts over the next year to explore some of these challenges and opportunities that you've highlighted. If you do want to be involved, and if you feel like your organization is well placed to be a guinea pig, we would love to talk to you more. Please get in touch with Abigail, let her know, and we can talk.
Yeah, we've actually been doing our own form of trying to get our data out of ReliTrax and into DACODS, as I mentioned, for 9 years. We've been actually got an active project going now with CCMCN, Colorado Community Metro, to do just that. So we're running directly with field to field kinds of things and that sort of stuff. So we've already kind of dipped our feet into those waters that way. And I know you guys have something else going, but this is the first shot we've had to actually do something in all this time. So we're kind of plowing ahead with an independent way of extracting data and transforming it, getting it into Snowflake, which is why I mentioned that. So be glad to participate. I mean, I think there's a lot we can all gain from that.
And we are tangentially aware of some of the efforts around Snowflake that are being done outside of the BHA. Obviously, BHA does leverage Snowflake internally as well, and we are running some pilots around ways that Snowflake can enable some of this stuff. So we are aware of some of those things. We are talking to some folks about those things. Again, reach out, and we'd love to explore how we might explore.
Yeah, there's a lot of mishmash that's happened over the years that has to be sorted out first, aside from just the traditional data transfer and transforming things that we would like to think is all there is to it.
Just real quick, we'll fix the problem.
Yeah. And I just sent my email to Abigail to sign up for the pilots. Yeah.
Awesome. Well, folks, like we were saying, that I think there are some folks that logged on. We did finish the presentation portion, and folks, didn't have a ton of questions, but the BHA technology team is going to stay on this call until all folks log off, but and keep the recording going. But if you need time back in your day, feel free to log off.
Hey team, this is John Malkin from HICPUF, and happy to give providers and others time to ask questions. I can always reach these folks generally at will, so interrupt if you need time as well. Is there a brief 30-second update you can give me, since I obviously was not able to join the first half, about the strategy? And I'm just going to say it the way I know to ask the question. It's probably not what you want me to say, but there's been the rumors over the years that we're replacing CCAR. Is there conversation happening as to replace it with what? Or if you can give me a 30-second update, maybe what you can share, that'd be great.
I don't think I can give a 30-second update. I'd encourage you to look at the website, and you can watch the recording as well as read the full report, because I think this entire body of research speaks to that question.
Perfect. So I will do that and reach out with additional questions. Thank you.
Thank you.
So I apologize because I unfortunately had overlap in appointments at the last minute. And so I wasn't able to jump on in the beginning. But at this point, our option would only be to go back to the recordings.
So we held 3 sessions this week, 3-hour-and-a-half sessions, and have been promoting across all of our networks. So all 3 of those recordings are posted on the project website, in addition to a way to provide written feedback. So we will, I don't know if you caught the end of the presentation, but the next steps process is that the BHA will be publicly responding to every piece of feedback that we receive, and then having 3 more share out and discussion sessions to discuss that feedback publicly. So the next time, that we would come together and have this type of discussion would be at that time, and that timeline is noted in the presentation. What else can I tell you? Other ways to get involved. I think signing up for the sign up email that we have been promoting as well would also be another great way. Also, if you need more detail than you're able to see on all of those materials, I'm always happy to schedule one-on-one time, but I think it would be most helpful for me if folks read through the materials prior to scheduling that time, if that makes sense.
Yeah, no, absolutely. I just, since we had this little bit of time, that's why I was going to say hey, I'm sorry I missed the catch on. And unfortunately, I only got the email from another entity last week, and I'm already booked up for the week. So I'm doing my best. But I will review it and I will reach out.
And Crystal, are you from HICPUF?
Nope, I'm a provider in with Dove Counseling.
Okay, got it. So yeah, so I think definitely sign up. We have been doing our best at outreach because we have like the BHA has a huge provider email list and we have a big provider email list. So sorry that that email didn't get to you in time. But rest assured, like tons of time for you to still like provide feedback, like engage in the feedback session. So this will not be like the last time that we, have these types of conversations at all.
Absolutely, I appreciate it.
Cool. Oh, when you're, oh, okay.
The 2024 deadline. Yeah. Based on my experience, that seems like it's tomorrow. I want to wish you Godspeed and I'll help every way I can.
Yeah, thanks, Brian.
We
Yeah,
lived
so
through, we lived through the Compass era and so forth.
yeah, and Justin has been a big champion of this as well, and I think it speaks to his point on piloting. We know that timeline, it seems both short and long, right? Like, oh, we have to wait for that long for updates, or oh, like that's coming up real quick. It depends on kind of who you ask. But I think that the way we're addressing that is like releasing value, whenever we can, as early as we can, and also being conscious of providers' timelines to not like force them to have to do things earlier than so although it seems short, I think because we're working iteratively, it is more realistic for that timeline.
Yeah. Well, I hope the EHRs will contribute. I mean, our whole company is based on that. We use it for almost everything. And without their involvement, that puts the burden on you and me. And they really need to be a part of this because interchangeability and interoperability is essential for the future for them and for all of us.
Yep. Awesome. All right. Well, since we only have two, Maria, can we answer any questions for you? Otherwise, I might stop the recording. All right. All right, folks, I think we're going to end the recording now and log off. Thank you so much for your time, and you will hear more from us in the coming weeks. All right.
Thank you.
Thanks so much.